When we're in the flow, release and let it go. Find that missing piece that makes us whole. When we're in the flow.
Our next topic is greatly debated in the scientific community. Joining us here in the studio is Dr. Jan Derks, one of the foremost experts on peri-implantitis. Welcome, Jan.
Thanks, Lotta. Thanks for having me.
I think a big question a lot of dentists have is it possible to fully avoid complications in implant treatment?
I want to answer the question in a way that, to be realistic, I think probably no. We can't fully avoid complications. They are a reality. We can minimize them. We can try to minimize the impact on patients, but at the same time they are a reality. So it is fair today that we speak to our patients about the probability of complications to occur and address them and then do everything that we can to prevent them.
So Malene, any comments from you?
Yes, I'm thinking that we know, as you say, that periimplantitis is a difficult task and difficult to treat, and maybe preventing it is the best tool we have. So I'm thinking maybe our patient selection is not, strict enough. Are we letting too many patients have implants? Is it for all patients?
Yeah, Malena, I agree. I think that patient selection is a critical point, and I think historically we have been maybe not critical enough. So going forward, I think in our risk analysis we are now better able to identify risk patients and maybe already in treatment planning to offer alternatives. But the most important part is to offer proper prevention to avoid the problem, as you say.
And now, John, please share your thoughts on the topic peri-implantitis and what we know today.
Now, talking management of peri-implantitis, I would first like to highlight something that was emphasized at the 2017 World Workshop in Chicago. And in diagnosing, in monitoring implants, what was highlighted was that it is really the probe. In other words, clinical parameters such as bleeding on probing and probing pocket depth that are the primary tool that we should use in monitoring our implants. The radiograph indicated here is somewhat secondary. It will of course support us in our diagnosis, but it is only obtained on clinical indication. And also, it is not so much the single radiograph. What was emphasized in Chicago, that it is the change over time that is relative to baseline that is interesting. So to be consistent with peri-implantitis, we would ideally be able to document progressive loss of marginal bone in this case. Now, managing peri-implantitis, both preventing and treating the disease, includes, of course, a good understanding of the etiology. So what is important for us to understand in the management, in the prevention and treatment of peri-implantitis is, of course, the cause of the disease, termed the etiological factor. And my answer to this particular question is that current evidence rather clearly points towards plaque and biofilm being the cause of the disease. Now, how can I argue that this is the case? What are the arguments today that prove that this is true? Well, there are two ways of answering this particular question. One is if we look back in time, looking at patient groups that have not attended regular maintenance care, that are not performing adequate plaque control. Well, this group of patients has a much higher risk of developing the problem. So this is one indicator. But I'll grant you that it is rather poor from a scientific point of view, as it is purely retrospective. So there's another way of looking at it, which is the stronger argument. And to illustrate this, let me show you a case. A case, clearly peri-implantitis. Clinical and radiographic findings are consistent with the diagnosis. The treatment now, consisting of an anti-infective approach. That is, we teach the patient how to brush, and then we decontaminate the implant surface. That is, we create access, we remove hard and soft deposits. And if we now follow the response to treatment over time, that is in this case for 12 months, we see that we reduce the probing pocket depth, the clinical signs of inflammation disappear, and we have also the radiographic response to therapy. In this particular case, no graft was used. So these are the tissues that the patient's own tissues. So summarizing this one example of a case in terms of data from studies, clearly indicating that using this approach, removing biofilm, we are able to arrest disease progression over time. So this is today the strongest argument that it is plaque and biofilm that we have to target. And if we first now discuss prevention, this is of course allowing the patient proper access to plaque control, and that is our design of the superconstruction. It is also the choice of components. We are talking about bone level implants. So you and I, on an everyday basis, choose abutments. This is where the soft tissue integration should occur. And here the dimension is of importance. What we should avoid, and this is something we could demonstrate in our group, are short abutments, increasing the risk for peri-implantitis. We have to, in case that the superconstruction does not allow access, adapt these, and in some cases even redo superconstructions that are not possible to clean. I will move now to treatment and discuss with you a little bit the flow of our approach. I will focus now on the established peri-implantitis situation, the moderate or even advanced cases. Not talking about mucositis, not about the incipient forms of peri-implantitis. Cases such as these, with pronounced probing depth, pronounced bone loss, the signs of inflammation, are, to our understanding, not manageable with non-surgical therapy alone. The patient will undergo non-surgical therapy, but it is rarely sufficient. So from the beginning, our planning already includes a surgical approach. Now, for this surgical approach, we, whenever possible, remove the superconstruction. It facilitates the surgical procedure, consisting of full thickness flaps, removal of inflammation tissue. We expose the implant surface. Then we chip off hard tissue, hard deposits, using a titanium-coated curette. And then a key tool for us is the rotating titanium brush that you see to the lower left. Irrigation in this case is saline only. There are no other active ingredients other than saline. And then we complete the procedure, of course, by suturing and by replacing the superconstruction. At 12 months, the response to therapy is indicated primarily by the probe. That is, we have a reduction of probing pocket depth. We have the absence of circumferential bleeding. In this particular case, there was a small bleeding spot on the buccal. And then, not surprising, in line with this positive soft tissue response, we also have a positive response radiographically speaking. And again, no graft was used in this particular case, so the recovery of the defect fill, includes only the patient's own tissues. The question now, of course, is these kind of results, indicated here now by two examples, are these stable over time? What can we tell the patients today? Well, long-term outcomes are something that we addressed in a recent publication in our group with Dr. Kakwak as the first author. The time frame covered here, 5 years after non-surgical therapy. In particular, surgical therapy rather, and in particular, we addressed the risk for recurrence and progression. After 5 years, we found that the proportion of implants showing disease progression or recurrence was 44%. This number is maybe rather quite substantial. Let me indicate to you now the primary indicator for long-term failure. And the strongest indicator was at 1 year after therapy, the residual probing pocket depth. In other words, if we, by surgical means, were able to reduce the pocket to a maximum of 5 millimeter, the situation was highly predictable over a 5-year time. Vice versa, if a deep pocket was also found at 1 year, that is residual deep probing, then the risk for progression over the subsequent 4 years was rather high, with 80%. So the primary goal, in other words, with your therapy, non-surgery or surgical, should be shallow probing pocket depth to provide stability over time. And with this, I thank you for your attention.
Thank you, Jan, for sharing your expertise. So, Malene, what's your take on Jan's topic?
Well, first of all, Jan, thank you very much for a very nice presentation.
Thank you.
I'm thinking that in my daily practice with my patients, it's my patients' compliance and attitude that has a major impact on the outcome. But I'm also thinking that our hygienists' tremendous work on education and prevention and treating the peri-implantitis is very important. What is your take on that?
I completely agree with you. I think the importance of prevention and the role of the dental hygienist in this work cannot be overemphasized. Of course, it's crucial, and that is preparing the patient and then maintaining the patient over time. So whenever we fail, both in preserving peri-implant health, but also fail in treating peri-implantitis, I think it is very frequently a matter of compliance and cooperation. So I think the role of the patient as well is of course very important in this.
So it's a collaboration between us as professionals and our patients to get the best outcome.
Exactly. Yeah. I think these pieces have to fit together.
I agree, yes.
In the end, everything we do as dental professional and as an industry is for the benefit of the patient to increase quality of life. And this is why Dentsply Sirona Implants has produced this manual, the supportive therapy manual, in cooperation with Professor Tord Berglund and Professor Mariano Sanz. And Jan and Malene, thank you so much for sharing your thoughts and insights. It's been a pleasure to have you here today. And thank you all for joining Inspiration Talks. And please don't forget to visit our e-stand at EAO Digital Days and the Dentsply Sirona Implants video gallery for deep dive sessions with our speakers. See you next time.